how many of you currently already have an advance directive and are here to sort of like, do I have the right one and want an update? Okay. And how many of you don't have any kind of advance directive? Okay. All right. Well, you fit pretty much the statistics in the country at the moment. So let me tell you what we are going to cover today. The first one is we've sort of narrowed it down to a 5-step advanced care planning process, because you're going to hear me say this a whole bunch of times. It really isn't just about the paperwork. It's way more than that, because you need to talk about it. So that's just almost as important as filling out the piece of paper. One of the things that we're provided in your handout is a checklist to select a healthcare agent. I mean, that's one of the main purposes of an advance directive, is if you're not able to make decisions regarding your health care, who is it that you want to be able to make those choices for you? And so there's a checklist that helps you give some thought to that, because oftentimes we make some assumptions about who would do a good job, and they might not be the best person. We're also going to cover some fact and fiction that's out there in regards to advance directives. And so maybe when we get to some of those questions, if at any time you go, oh, now I have a question, what about this? Really, I'd like it to just be a dialogue. Feel free to just raise your hand, and I'll say I'm going to get to that, or maybe I can answer it right then and there. And then lastly, one of the things I'm most excited about that CODA Alliance developed, and I'll do this several times throughout the day. I'll be pushing these buttons, was with Dr. Mencken, we developed a tool called Go Wish cards. And it's a deck of cards, and you're going to get a chance to work with them later today, that helps you sort of look at what might be some of your values should it become time towards the end of your life. So that with these cards, you can have a conversation with your healthcare agent to let them know ahead of time what might be important to you. So that'll be our hands-on activity a little bit later on. So the very first step in the 5-step process is to think. And as you can see, that you got to think about it first. So you're obviously thinking about it because you all came today. And then the second step is to talk about it. We'll talk about it today. You'll go back and talk about it with your loved ones. Then you need to, after thinking and talking about it, then put something in writing, which would be the advance directive. And then we're going to talk about, okay, now you've completed it, what the heck do you do with it? Who do you distribute it to? Where does it go? And then we'll also talk about updating it, because unlike some pieces of paper, just because you do it once doesn't mean you're never going to do it again. So for those of you who have one, it's great that you're here today, because maybe we'll talk about some things that you'll think, yeah, I'm comfortable with what I have in my advance directive, or you might think, nah, I think I might want to do some updating. Like, oh my God, let's just think about, I've had a good life, I'm at a very old age, and it's, looking like it's pretty close to time to die. So if you were to think about that, maybe you already have thought about it, think about it, I'll give everybody a few minutes. What would be important to you? So I'll give you a minute to think, and then if some people will share their thoughts. So this would be your ideal. If you could say, it's the last day, night of my life, what would be something that might be important to you? Anyone want to volunteer? Yes.
That my wife and my children and grandchildren would be there.
Okay, so you'd have family and loved ones around you. Okay, good. Yes.
No suffering.
Okay.
No, just die in your sleep.
Right. Wouldn't that be nice? No pain and so forth. That's one of the most common choices. What else?
Well, mine would be, I saw a neighbor pass off, and the family came in, and they got this big bin and threw everything she had in the bin. And my thinking is, my good death would be my husband beside my side, but make sure everything, my life is decluttered. So he
Okay.
doesn't have to go through that, because it was just painful for me to see all this lady's valuables just go into the trash.
Right, right. So to have your affairs in order, have things organized so it wouldn't be a burden to your loved ones. All great thoughts and very somewhat common. In fact, most Americans, these surveys have been being done for several years, and they continually come up with the top 3 things are that people would prefer to die at home, that they would prefer to be pain-free, that's the suffering part that we talk, and they don't want to be alone. Again, that's, and oftentimes it's with their loved ones and so forth. However, here's the big however. What's the reality? 70% of people say they would prefer to die at home. However, 70% die in a hospital, nursing home, or long-term care facility. Now, and again, I want to say up front that I'm not making value judgments of it. There are totally appropriate times when people, die in hospitals or even in a nursing home or long-term care facility. They may not have loved ones who have the ability to care for them at home. So it's not a bad thing that people die in other places. It's just that we have this perception that we want to die at home. And if it was really important to someone, here's one of my number 1 tips, that if at all possible, and this is something you might put in an advance directive, that I would prefer to die at home, and generally that would mean with some hospice care. And that, particular nonprofit hospices can support your family and so forth in making that happen. So that's just tuck that away. If that's important to you, it might be something you'd include in your advance directive. Another reality is that 80% of people say that if seriously ill, they would want to talk to their doctor about end-of-life care. However, 7%, only 7% have had that conversation with their doctor. That's a huge gap. And if you notice that 70% of the people are dying in hospitals, but they haven't had a conversation with their doctor, you can see how there could be some conflict going on if you had some very strong preferences in terms of the care that you wanted. So again, if you complete an advance directive, it certainly is worth, back to the question about, yeah, you probably do. If you have a primary doctor that you have a relationship with, you want to talk to them, him or her, about your advance directive.
But just a question there.
Yes.
When you're in a hospital, it's not your primary care doctor that's taking care of you.
Exactly. So again, back to why you're also going to hear me say over and over again, whoever you pick for your health care agent, it can be a relative, it doesn't have to be a relative. It's critical because they're going to be the person at your bedside. They're the ones running interference. They're the ones talking to whoever it is on duty to make sure that your wishes are carried out.
So if you have family that's out of state, and you wish to have them as your healthcare agent, but if they're not available, would it really be better to find someone locally?
That would be what I would encourage, and we'll talk about that a little more when we're talking about healthcare agents. Okay, and the other reality, and this kind of fit our group here, 82% of people say they think it's important to do an advance directive, but only 23% have actually done it. And if you notice by the show of hands, I'd say our stats kind of echoed that. But within a month's time, we're going to improve that number in this group, aren't we? I've given you a whole month. Okay, so, all right. So now, as we said, we've been thinking about it, and we're going, okay, fine, now we have to talk about it. And again, you'll see, I'll say, it's about the conversation, not just the paperwork. And so sometimes this could be the biggest challenge. Maybe the first challenge was getting into this room. Now the second challenge is if your loved one isn't sitting next to you, it's going and having that conversation. How do I bring this up? And my experience with, as Ann said, I've helped hundreds of people do this. And I don't know, maybe it's just how the universe works. So maybe I'm the person who wants to talk about my advance directive, and maybe I have an adult child. Well, then the adult child, oh God, don't talk, I don't want to talk about that. I don't want, you're going to die, da, da, da. Or I'm the adult child talking to the parent, And the parent goes, I don't really want to talk about that right now and put it off. I don't know why we don't always generally match up with everybody wanting to talk about it, but usually there tends to be one or the other. So here's some suggestions that if you need to have this conversation with a loved one, and when I use the word loved one, that's to cover family members, that's to cover people who you consider family. They might be the people you're picking for healthcare agents. So I just want to define that term very broadly when I use it. Yes?
We're talking about having this conversation and documentation done, but what is the definition of you're in an advanced situation, this document now becomes the deciding factor of what happens to you? Are you no longer breathing, or you're very sick, you can't think?
That's an excellent question. The time that an advance directive would be used would be when you were no longer able to make decisions for yourself. So if you're not able to communicate, the advance directive gives your healthcare agent the ability and the responsibility and the legality to make decisions on your behalf. Now, with that said, you can write out your advance directive, and you could be very, very sick, and as long as you can communicate, you can change your mind no matter what's written in the advance directive.
But somebody has to designate that you're in that space, that now somebody needs to think about what to do. A doctor needs to say you're in that phase? Is it
Yes, but it's usually pretty obvious. I mean, you can't communicate, so that is usually not the controversy. And in fact, in some advance directives, you can have your healthcare agent have the ability to help with decisions even if you're coherent. Like as an example, and I use quite a few personal examples. My own mother-in-law is able to communicate with us right now, but she, because of medications and some dementia has set in, she's comfortable with us being able to help her with those decisions as her daughter to help with making those decisions, even though she can communicate with us. And you can check that box, and that gives the doctor the ability to talk to her daughter and make decisions. Did I answer that? No?
It's still unclear to me, because you're saying that if I at some point check on the box that says I may still be able to talk and I may still think that I want X to make those decisions, at what point does that become the control of the situation?
It only be as long as you can talk, you can communicate whatever it is you want, no matter, even if you check that box. It's really only critical when you cannot communicate, and that is really very obvious. That you're usually unconscious, or I guess there could be a situation of advanced Alzheimer's or whatever, but you're still not able to communicate.
But somebody's making that decision, right? It's not you who's no longer capable. It's a doctor who says, right?
Yeah.
It's not a lawyer or your...
It wouldn't be a lawyer. With that, go ahead.
If I say that's what I want,
Right?
and I'm no longer there, can the kids override that? Or can the doctor say, sorry, kids, or whoever is there, this is what says in here. Who has the final word? Because I hear that maybe it's a TV movie or something.
So, this is going to be a tricky answer. The legal way it's supposed to go is if you've designated a healthcare agent, that healthcare agent is going to communicate to your doctor what your wishes are. The doctor is supposed to follow those wishes. But what I can tell you is that is not 100% guarantee. Have examples, unfortunately. And I guess until someone sues big time the doctor who doesn't follow the family's wishes that were communicated in advance directive, are we going to be able to prevent that? But what I tell people is you increase your odds of getting the care and having your wishes honored if you have it in writing in an advance directive. Because what a family could do if they're in disagreement with the doctor is go to the hospital ethics board and ask for a hearing to say, we have in writing, we have had conversations with, our loved one, this is not what she wanted, and this doctor is not honoring, and then usually it gets taken care of. So, so while it's no guarantee, what I can also guarantee is if you don't have an advance directive, no matter what your family says, in the state of California, the doctor is legally responsible for treating.
Yeah, that's a bad point.
Yeah, so that's why if you have strong feelings about what you want, that's why it needs to be in writing. So good questions. So this is why we have these conversations. And so ways to bring it up if someone who you need to talk to about it is uncomfortable is, I always say, if you're trying to urge someone else to do an advance directive, you need to have done your own first, which I have. So share an article or story on the topic. I don't know how many of you saw the series that Lisa Krieger did in the Mercury News. That's a great entree to help people talk about it. It's like, oh my gosh, I didn't know about this. Let's talk about what we want to do or what I want. Sometimes, there's TV shows or a movie or maybe there's something on the evening news. There's something about the timeliness that makes it a more natural conversation, not quite so contrived. So use that opportunity to bring it up. Other ones are maybe you're taking a loved one to a doctor's appointment and say, we really should be talking to the doctor about an advance directive. So why don't we get some paperwork and do that? Or sometimes it does get married in with the trust kinds of things in regards to an advance directive. If that provides an opportunity, let's get all the paperwork in order. It's another time to bring it up. What I often see, or people who come to me for help, is generally in regards to someone else being very, very sick, or maybe right after someone has died. And part of that motivation comes from one of two things. One is like, oh my God, I never want that to happen to me. Or, wow, if I could pick the way I died, that's the way I would want it to be. And so that, in talking about that, so what is it that you want or don't want are part of the conversation that need to take place about what is important to you around end-of-life values. And this is in your notes in the back. I gave you some resources. But this conversation project is a great, very simple tool. They have lots of good questions, to get it, people around the kitchen table and just talk about some of those possibilities and how different people feel in your family. And then, as we said, another great way for you to now go back and talk to a loved one is to say, I went to this workshop, and here's what I learned, and I need to talk to you about this, and oh, by the way, here's these cards that we used. So as I said, we'll go over those in a little bit. So now let's talk about the literal documentation part. And the number one, let's ask you. So, true or false? You do not need a lawyer to complete a California advance directive.
True.
Anyone disagree? Very smart group. You do not have to have a lawyer complete your advance directive. Now, as I said, a lot of people end up doing it as part of a trust or in the lawyer's office or whatever, but you don't need to. You can do it on your own. And then number two, there is no official standardized form in California. And that's sort of a good news, bad news thing. You can go on the web, you can find all sorts of different standardized forms. There are some that are affiliated with religious groups because some religions have some very specific end-of-life care rituals that they follow. So if there's something really important to you, I'd urge you to take a look at one like that. Again, the sample that I gave you today is the one that, just for the purposes of the discussion, but you can also find that on the CODA Alliance website if you want to make more copies and fill it out and so forth. And that address, I believe, is on the bottom of that sample form. But here's, yes, sir.
Have you heard of anybody having two directives? I'm only afraid there could be a conflict.
There could be, and actually that's why they're dated and signed by people, and whatever the latest date, excuse me, would be.
So if you want to modify one,
You have to,
if it's not, then you do that.
right. That's an excellent question, because if you do make modifications, you have to do the whole form over. It's not like a will where you can just put attachments. You have to do a complete one all over.
Go ahead, another question.
Yes.
What is a durable power of attorney for healthcare? How does that differ from the?
That term is, well, that is an advanced directive. But they use that because it's like, have you heard of the durable power of attorney for, is it finances? Finances. So it's a legal term. So the one is somebody's going to be responsible. You're giving them the authority to deal with your finances. Durable power for health care is your advanced directive regarding your health care. Some people that's the same person. Some people it's not. That's really up to you. But here's what you need to know about an advanced directive form. There's three parts. The first part is about choosing a health care agent. And maybe for the purposes of right now, if you'd, can I borrow yours for a second? If everybody will just pull the sample one I gave you, take a look at that so this will make a little more sense. So part one is about choosing a health care agent, and you can fill out just number one and do nothing on part two, which is where you want to give more information about your health care choices, or you can do both. You can do one or the other or both. We're going to, of course, urge you to do both, but here's what I know happens to some people. They get real hung up on number two, like I don't know what to write about what my health care choices are and so forth. I would say if that stumps you too much, just do number one and have the conversation with the person who you choose as a healthcare agent. The only other thing that's required is part three, which is where you need to have the form signed and witnessed. So those are the only elements that have to be in it, but what you put in like number two can be as broad or as narrow as you'd like it to be. And we're going to talk about some of those examples. So, true or false? In California, if a person is unable to make his or her own health care decisions, his or her spouse legally becomes the surrogate decision maker.
I think that's false.
It's a
I think without the directive, it doesn't automatically go to the spouse.
I think it goes to the spouse.
We have some trues, we have some false.
It's false.
Okay. Ding, 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 ding. False. In California, there is no legal hierarchy for making health care decisions. So if you have not designated a health care agent, here's the scenario. I'm lying in the hospital bed. My husband feels one way, my son feels another way. If it's not in writing that either one of them have the decision-making power, they could take it to court, spend all that legal money, and in the meantime, the doctor is going to keep me alive at all costs to the family because there's nothing that is considered compelling evidence for decision. So the other place that I really urge people, and if you have children or grandchildren and so forth, it also applies for, and where I really counsel people is like, okay, my child just went off to college. He's over 18. I, as the parent, now have no legal authority if something were to happen to him. In fact, if he's away at school and a hospital calls me, or I find out he's been in an accident, the hospital doesn't have to give me any information, let alone do I get to have any say in his care. So again, if anyone has kids, grandkids, 18 and older, every single person needs an advanced care directive. Because one of the things in a younger age, the possibility for them is probably going to be more around an accident. And so again, who's going to make decisions for that young person's care? Yes, sir.
What about just the spouse? If there's no other relatives, can the spouse make the decisions legally?
Only if it's in an advance directive. Now, what will happen in reality, again, a doctor will probably go, okay, you're the spouse, you would know. But legally, they don't have to. And if there is any inkling of conflict, it could be the neighbor comes in and says, oh, she didn't want that or whatever, and you're the husband. If it's not in writing, the doctor doesn't have to do what you say. What do you think? I'll let you read that yourself and tell me what you think the answer is.
Probably goes to A first.
I think it's D.
Well, it's actually E. It could be any of the above. Could be any of those up there. The worst case scenarios are when it just tears a family apart and then, and then going to court and so forth. So there really are some very negative consequences. And the more you have a lot of diversity of thought in a family, the more critical it becomes. That you put the things in writing.
And can't the doctor make the decision if there's no advance directive?
No. Well, the decision the doctor will make is they will treat you at whatever, all methods possible. At no, it doesn't.
No expense.
Exactly. So in addition to making your health care decisions, which of these decisions can your health care agent make on your behalf? Correct, E. That healthcare decision, this is again, you're no longer in a position to be able to verbalize or communicate your wishes. Your healthcare agent can decide whether you're going to die at home or go to the hospital, whether you can die a natural death or be put on life supports, or whether you get a visit by your person of faith, whether you get hospice care, and so forth. So those are the responsibilities of a healthcare agent. As we said, not only that, but they also are the ones that can decide on your doctors, nurses. I mean, I've had families not be happy with the doctor, and so as a healthcare agent, I can get another doctor for my loved one. Medications and tests. In the state of California, you have the right to refuse medication, tests, and so forth. You do not have to receive treatment unless you okay it. So if I'm the healthcare agent and I have a loved one who is in the end stages of a natural death, I am more than likely going to say, no, you're not going to run that test on her. For what's the goal? The person's dying. Why would you torture them that way? So I can, as the healthcare agent, can refuse to have that test. And then also I would, as a healthcare agent, be asked, what should happen to the body and the organs after you die. Unless, back to the donating the body to science or a university, I can say, I know that her request was this, here's the paperwork, and here's what's supposed to happen.
So a question,
Yeah.
on the decision to die naturally or however, is your choice, is it required that it be a legal kind of activity?
Yes. I know what you're saying, yes. And that, again, this gets into a touchy area, so I want to be really clear that
What was the question?
it would be that are the things you put in your advance directive regards to the end of your life have to be legal. So one of the things that I think you were referring to is in the state of Oregon, there's what's called physician-assisted suicide, which is if a person was at a very end stage of their life, could choose to have the doctor hasten the death. Well, the doctor has to agree that the person's dying and so forth, and which, by the way, I think only 2% of the population in Oregon has ever opted to have that. But what I was going to say is I want to be real clear when I talk about this that I am absolutely not advocating any choice, right, wrong. It's a very personal decision, any of these. And in fact, I have a friend who, I mean, I will say I do have biases, but I'm trying to be clear when I'm being biased, who was telling me, we had a conversation about this, and he was like adamant about he wanted, if something happened to him, he wanted everything possible tried. And because he believed, medical science changes so fast that what's to say they wouldn't have the cure for him while he was in a non-conscious state. And so he really was adamant about did not want to be taken off life support. And so I thought, okay, that helps me understand how this person thinks and so forth. So it's why you have to have those conversations with family members. The other end of that, my own mother has said to me, when the time comes, I said, Mom, let me be really clear. I don't want you to suffer, but no, there is no way that I'm personally going to be able to do anything to hasten your death. I need you to know that. I can't do that.
But you might know somebody.
So, yes. So anyway, right, exactly. So that's why I'm saying it was a very good question. It's why you need to have the conversations with the people and why you pick a healthcare agent who can honor what's important to you. It would have been very hard for my, friend Michael to ever be his healthcare agent because I was like, the costs involved and, when it would seem so futile to me, I couldn't be his healthcare agent because I couldn't make that choice. So anyway, very personal decisions, but ones that need to be discussed. So which of these are a legal requirement of your healthcare agent?
How come a family member, like a friend or something?
See, it's like, it must be-
Right, it's C.
Oh,
It's C. The only legal requirement is that the person be 18 and have decision-making capacity, which means, they have to be of sound mind. So, and part of the reason this also gets tricky is with very elderly couples, if they've chosen each other as the healthcare agent and and have put the papers away years ago, and then one of them has severely declined, say to something like Alzheimer's, they're not going to be able to serve in that role because they don't have decision-making capacity. So, again, in choosing a healthcare agent, it's really important that he or she knows you personally, and your values, and that you trust him or her to make decisions for you. And that second line is really, it's not just the trust part of it, but that you feel comfortable that they have the capability. And that's why if you go in your little workbooks that I gave you, there you go. If you'll go to page 5, you'll see there's a little checklist. Everybody find that? The handbook is the, that one. Yeah, right. It's the thicker handout, right. Everybody found that? So perhaps you've been thinking about someone or you know for sure who you want. Kind of just go through and maybe make a check mark down that list and see if you think it applies.
Another question.
Yes.
So you choose an agent who's whom you trust, but whom your surviving relatives want to challenge. This directive does not prevent that possibility of legal.
No, it would. So in other words, the person that you pick knows you, they know what you want, they know how you want it handled. You do an advance directive, you name that person, and all this whole other group of people in your family challenge it. The doctor has to listen to the person who is specifically chosen by you.
Okay, but does the family have legal right to challenge?
Well, they always have the legal right, but the odds would be very much against them. The courts call it clear and compelling evidence. So the more clear you are in terms of who your agent is and what your wishes are, it's going to be a whole lot harder to overturn that. I strongly suggest that you select one person who would be designated on your health care, on your advance directive, as your #1 agent, and that you suggest an alternative. Because in reality, the doctor is going to want to talk to one person, not a whole family, even though there's a lot of cultures where it's a family-made decision that one person is the spokesperson, so that the conversations go on within the family, that person speaks with the doctor, and that you have an alternative. You can do it all. That's definitely one way you can do it. In terms of the practicality, for most people, you're going to want to choose a first and a second alternative. Okay? So one of the things, let me go back, finish talking about this. So in looking over that list, what are some things that you might not have thought about until you read the checklist?
Number 13.
Which is?
The ability to handle conflicting opinions between family members.
Right. Right. I mean, and I'd say that one is important, as well as the person has got to have the personality to be able to maybe stand up to the medical community, to say to the doctor, look, we've talked about all this, and this is not what my mother, my father, my aunt, my uncle wanted. A person who's a little more shy and retiring, you may not want to consider them as your best alternative.
But they also might have different religious ideas than you have.
And you certainly, if that's important to you, that is not someone that you would want to pick. Which kind of leads to this one, which is true or false. It's a good idea to name the people you want excluded from making health care decisions for you.
Is there a place on the form to do that?
That's one where you would put it on a separate sheet of paper to have, here are my wishes, and here's one of the things. And I actually think there is on the sample form I gave you. It was like on the page. It's 1E on page 2 of 4 on the advance directive, the sample advance directive. And why would that be important?
Well, it's kind of a double safety, because you've got the authorized person with witnesses and everything.
Right.
And if somebody tries to step in and take over that,
Right.
you have another one that says, no.
Right.
No, they don't want this person here.
Right.
Again, signed witness.
Right. It makes it
Legal
right. It makes it totally clear, because exactly either for religious reasons, I had a friend talk about it in terms of the black knight or the white knight with the black hat or something. So you've got the number, and I don't mean to pick on sons, but you've got number 3 son who's been off traveling the world, never gotten along with the family, mom is dying, all of a sudden he comes writing in, he's feeling all this guilt that he hasn't been there for mom, and so we should do this, and it's in total conflict with the people who have been designated as the healthcare things. It just does exactly that. It gives you some insurance and it's usually those rabble-rousers, the ones who are most vocal, who are going to, by being that vocal, are going to make the medical community more nervous. Oh my God, it's always about dealing with the conflict, that it could delay things. So
it's it's also, there's a subject there's an elephant in the room we're not talking about.
It's always money.
Money.
Well, it can be that too, right?
Inheritance
Yes, yeah,
can cause the conflict.
It-
That's why you need ironclad.
right. So I really, and for those of you who might have a situation like that, you might want to take some notes on this next slide, because I think this is an excellent, well, the answer is yes, true, you should. So, and she wrote in hers, I dearly love my son David, but because of our situation, he shall have no part in healthcare decisions on my behalf. Now, if I'm a judge reading that, that's pretty clear and compelling evidence that David should have no say in the decisions. Again, now we're talking about a lot of these kind of healthcare decisions. If you're particularly concerned about some kind of healthcare things, you want to spell it out in your advanced care directive. And where a lot of times it gets into things that people have strong feelings about are things around life-sustaining treatments. And so which of those would you think might be the most important consideration about receiving a life-sustaining treatment? It absolutely is A. So how much is that treatment going to help or hurt me or the person I'm making decisions for? And is it going to be a benefit or a burden to that person? I loved one of the expressions or questions that my friend Dr. Menken would say to her families in her care, and she would say to the person, you know, if I could give you more days like today, would that be a benefit or a burden to you? You know, so that helped her then decide on terms of presenting options for treatment. So if you're in the position of being a healthcare agent, you want to remember this question to constantly ask the doctor. Is this going to be more helpful to my loved one, or is it more hurtful? Is this going to cause them more pain and suffering? You know, what's the goal of that treatment? Is it going to be a benefit to having, you know, giving them more days of comfort, or is it going to be a burden? And here's just some examples. It might be a benefit if it helps me live longer so that I can do blank. And I will say to this particular one, the longer I live, the more I'm amazed at what people will endure when they have a goal. I've been astounded at the personal suffering that I've seen people go through because they wanted to see a grandchild graduate from high school or college. They wanted to see their first grandchild born. They wanted to be at a wedding. Whatever it was, if people have goals that there's some reason to compel them to live, they will endure a lot. And so it gets a little tricky saying, if I'm in this situation, that I don't want to be here, because you don't know till you're there. It might be a benefit if it helps me be able to eat or walk or understand a joke or feel happy. Again, I might be willing to put up with a lot if I can have what's important to me. And maybe all that's important to me is I could be in bed and not be able to move, but my grandchildren are around and entertaining me. That might be okay quality of life for me at that time. It might be a benefit if it just helps me live the way that I want to. And if I asked each one of you, that would probably be a little different for everybody in the room. Could be, and it shows respect for my religion or faith. Again, if you have certain spiritual beliefs that are critical to you around end of life, I'd really urge you to put some notes in your advance directive about that. Could be a burden. That treatment might be a burden if it causes me a lot more pain, if it just stresses me out because you're making me do all these things I don't want to do. If it makes me look bad or I'm unable to care for myself because you've now burdened me with some kind of treatment. And if it takes up all my time or too much of my money. You know, one of the things that comes to mind on all this is people who end up having to go on full-time dialysis. Again, I might be willing to do that and put up with that if I have a reason to keep going, or I might choose that I've had a good life and at this point in time, I'm going to refuse having dialysis. I have that right to do it. So, true or false, tube feedings or IV hydration might increase a patient's suffering at the end of life?
Might?
can't tell.
Okay, so this is a very important one, and it's very emotionally charged. It's true, it could. It actually may prolong the dying process but not increase the quality. Nutrition delivered by tubes is a medical treatment, and the word starvation is an emotionally charged word that does not describe the cause of death. And the reason I bring up these two things is because now let's put yourself in the role of being the healthcare agent. And you're asking me to withdraw or not give my loved one artificial nutrition. You mean I'm going to starve them to death? I think we'd all probably, in this culture, kind of realize, we sort of equate food with love, and if I'm not feeding you, I don't love you, and you're asking me to make that choice. So I'm trying to change the terminology for you so that you can understand that what happens when the body is naturally dying, it shuts down and does not need or want food or artificial nutrition or hydration. And in fact, as those organs are shutting down, as you invade them with all this additional fluid, you could increase the discomfort for a person, either their lungs filling up or their body retaining the fluid and so forth. Again, it's different from every single individual, but keep in mind what I'm saying is that the person's body is actively dying. They're in end stage dying. So it is a medical treatment that some people decide that they don't want at the end of their life. Yes?
I can speak to that. Dad was primary care giver to Mom, and he was always trying to get her to eat. And it wasn't until he was dying where he said, the only thing I regret was making your mother eat when she didn't want to, because now I understand.
Right.
You just don't want to.
Well, and here's the other thing. I mean, how do you know this information? I mean, do I have any nurses in the room? Do I have any doctors in the room? I mean, there's nothing like in our day-to-day lives that teach us these things. And so generally, we're getting this kind of information in the worst crisis times of our life, of having to let go of someone we love. So that's why I know it gets a little like, oh, really, do we have to talk about this? But the reason I want to introduce it is to just plant the seed so that if you were to become in a position to have to make those decisions, to give you just more to, give it some thought. Because, in conjunction with your doctor, nurses, and so forth. And again, this is where if you are in hospice care, they do a fabulous job of being able to explain all this to you when it's appropriate, not appropriate. The book is listed in the back, and it's called Handbook for Mortals, Guidance for People Facing Serious Illness. This was written by a medical doctor, but what I love about the book is it's written in normal people English. Like we can all understand it. And she does a great job of talking about some of these particular issues and putting them in lay terms and, questions to ask and so forth. So afterwards, if you want to come up and take a look at it. But anyway, I have given out, lots and lots of copies. You can get it on Amazon. She's just a real leader in the field. She would be one of those doctors who would give you the information about artificial nutrition and hydration. So definitely take a look at that if you're interested. So I want to make sure you get a chance to play with the cards. So I'm going to move us along a little bit here. Here's another one that when all else fails, if you wanted to have another comment in your advance directive, it says, if there is a conflict between the healthcare instructions I have given and what my agent thinks best in the moment, given new information, for reasons of family needs, to travel for instance, I give precedence to my agent to make decisions in his or her best judgment. I think this could be simplified, and in fact, what I put in my own advance directive, having gone from 20 million lines of details to, I've talked about this with my family so much that I do believe that, I'm not sure how I'm going to die or what the circumstances are, but I have confidence that my husband and son We've talked about it enough that given whatever the circumstances are, they're the feet on the ground. They know what the circumstances are. They're going to be able to make the best decision based on what they know. So I didn't want to tie their hands by putting a whole litany, or the doctors, like this, or whatever. Just talk to them. They'll tell you what to do. So you can go detail, you can go simple, whatever. It's just another thought in terms of precedent statements. True or false, if emergency personnel are called, the only way they will withhold CPR is if the person has written no CPR in his or her advance directive.
They don't have.
It's false.
They don't have a copy.
Right, because in the paramedics, there's a specific form called DNR, or now this is where the POLST form comes in, that has to have a doctor's signature. And a doctor's only going to sign a DNR or a POLST form if you are in the end stage of life, meaning that you probably have, in the doctor's best judgment, you have a year or less to live. So no matter what you put in, that, I forgot what I just said. I know I said 1 year or less. The key point is it has to be a signed form by a doctor, and the doctor's only going to sign it if in his or her best judgment you have less than a year to live. So in other words, this is a person with, say, a very advanced disease or illness. The doctor would not be surprised if you were to die within the year. Then they would sign it, because reason is that with CPR, when you're in that end stage of dying, that people don't survive that CPR. And in fact, what you've done is you've probably injured their body. Most survivors of CPR have about a 50% chance of sustaining a major brain damage. And again, that depends on how fast they get to you. And if you're already in a weakened state because of a diseased body, they might be able to bring your heart back, but you're gonna be brain dead. So, or brain damage. CPR works best for people who are otherwise healthy. Like if I drop over tomorrow, I'm pretty healthy. Go, okay, if I drop over, give me CPR, I'll probably come out of it. But if I'm in stage 4, been in chemo cancer treatment for the last 2 years, and my body's weakening, I'm probably not going to survive it. So don't assault me with it. But the POLST form, which is actually a new form within the last year, 2 years, and it's better than the DNR. Oh, but I want to make sure I'm clear on this. So, because this is a confusing issue, people will put in their advance directives no CPR, and if you bring out that advance directive and says, see, she didn't want DNR, the paramedics, without an official doctor-signed form, have to treat. They legally are responsible for treating. So that's why you need that second form. The POLST form, which stands for Physician's Orders for Life-Sustaining Treatment, is one that the doctor is going to go over with the patient and includes more than just CPR. It has some things having to do with, I believe, I've got the form in here, like artificial nutrition and that sort of thing, because that form is what they need in the hospital, so they know the doctor has been part of the conversation, because too many times a person will get transferred in the ambulance, get to the hospital, and their wishes aren't followed. And so that's why, and it's on a bright pink form, and it's hopefully cutting down on additional treatments that people don't want. Yes?
I understood that form was actually there in case somebody has to come to the house, an ambulance.
You want both. You want it, yes,
So,
yes.
And that's basically to tell the paramedics how to treat
Right.
the situation.
Right.
That.
You want it in a very visible place when you have someone who this would apply to. Yes, they're going to have it at the hospital. You want to post it in the house. Most people, it's a refrigerator by the front door.
Do you have a resource for finding out what the life-sustaining treatments that you might not want are like?
A great resource, again, it's on your list in the back, and it's an online one, and it's the California Coalition for Compassionate Care. This is back in your big handout. Am I right? Did I put that on there?
Yes.
They do a great job of one-page sheets on a variety of life-sustaining treatments and do a nice job of, saying,
Know what you're saying yes or no to.
yes, exactly. It's a really simple, easy to access resource. I was on their statewide advisory board, and they just continue to do really good work. So, okay. So, true or false? To make your advance directive a legal document, it must be signed and dated by 2 witnesses and a notary.
False.
One or the other.
False. Don't,
Boy, we got some strong feelings on this one. Yes, false. Or, right. Okay. But here's a little reminder. The witnesses, pretty obvious, they have to be 18 or older. They can't be your healthcare agent, so it has to be somebody else. If you've named David as your agent, he can't be your witness. If you are filling out like you're with a loved one and they're in some kind of a facility care place, they can't be one of the signatures. One of the witnesses, because you're going to need 2 if you're not having it notarized, can't be expected to inherit, okay? And if, in fact, you are helping someone with one in a skilled nursing facility, the ombudsman of the facility has to also sign the form, okay? Okay? All right, so, real quick, what else do you need on there? Yes?
we were just talking about, her mother is in.
Skilled nursing facility, I do not have the signature of the ombudsman. Does that mean that the directive is still?
No, well, did you do the directive when she was in? Oh, then you're okay. It's only if you were completing it when she was in. Right. No, you're all right. Okay? But good question. See, that's why you came to the workshop. Yeah. So, all right, in terms of distributing it, I sort of subscribe to the make lots of copies and give lots of copies out. So what's always going to happen is you're going to keep the original. Even if you take it to the doctors, they're going to make a copy, give you back the original. You obviously want your healthcare agent to have a copy as well. And please have had a conversation with them before you give them a copy. Honest to God, I have heard of situations where I've had a person in a class say, well, I got a call from the hospital and said that I was the agent and I needed to come and make decisions. And that was the first they'd heard. Could you imagine? That's just awful. So, give your doctor a copy. Make certain that it gets put in your medical record. So at Kaiser, you just go to whatever the administration office is, they take it, they get it online and so forth. I'm big on at least put something in your wallet that says you have an advance directive and where to find it. So again, if you're in an accident, they know they're supposed to ask or look for something. And if you're entering a hospital or a nursing home, take a copy with you. In fact, on this one, I just want you to know, because I practice what I preach, I just got back from Peru last month. I took my copy and my husband's copy with us. Even though, who knows if we had to get treated there, if they'd honor it, I figured I was not taking any chances at least. It gave them some direction and they knew who to call. Yes, he did. We talk about it, we joke, it's like if you come to my house for dinner, we're likely to talk about these things, So my son, who's grown up with it, it's like it's normal conversation at our house, So, and then lastly, to update. So for those of you who do have one, and for those of you who are going to have them done within the month, you're going to update it when any of the 5 Ds happen. And the first D is every decade, at the bare minimum, 40s, 50s, 60s, 70s, 80s. Yes, so do it as a birthday thing, at the very minimum. If, in fact, there's a death, in other words, my healthcare agent died, or my second alternate or whatever, it's probably a good time to do another update. Divorce, we've had this one happen where it's like, oh, people got divorced, forgot to change their advance directive, guess who gets called? May or may not be the person you want making choices for you. A diagnosis. So oftentimes if people have been diagnosed with some kind of a severe illness and they have some inkling on what the progression of that disease might be, that might influence their choices in terms of their medical wishes, and you'd want to get that in writing. And then again, if diagnosis sometimes can lead to decline, or just, decline because you've lived a rich, long life, and at 100, maybe what I want in my advance directive might be different. So you definitely, those are specific times that you want to do updating. End-of-life values based on a whole lot of research in terms of the most common values that come up with people. There will also be one in your deck that says the wild card. And the wild card is because there's going to be things that are not on the cards that might be important to you. One that comes up is like having my pets taken care of when I'm gone. Whatever is important to you. You can have 10 wild cards if you want, if we didn't cover it. So you're going to take the deck of cards and you're going to sort it into 3 piles. One is going to be what's really important to you, very important, what's somewhat important, and what's not important, okay? So just divide those into 3 piles. Just for the purposes of today, go through them fairly quickly.
I know it's all very important. Don't you want to be? Not being a burden. I don't know.
And again, the words that are on the cards, it's your definition. So it's like, it's whatever you mean it to be. Some people end up having things that are important to them, but they've already taken care of it, so they don't put it in their very important pile. So use this in whatever way works for you, because if you've got them divided into 3 piles, you now need to take your very important pile, and the point is to get it down to 10. Again, you can do this recording in whatever way works. There's not a right or a wrong. It's whatever works for you, because this chart is one of the tools that you can use to have the conversation with your healthcare agent. Because here's an example. Have you run across that card that says to die with dignity? Everybody seen that one?
Yeah.
Okay, so let me have some examples of what would to die with dignity mean to someone who will tell me their answer.
Not dirty.
Okay, not dirty. What else?
No machinery.
Okay, what else?
Well, people might be aware that I'm dying. Wouldn't that be kind of something? Just
What?
lying over there, nobody knows what's
Right.
happening.
Okay, well, here's the point I'm trying to make. That is, it's very different from one person to the next. So if you're my healthcare agent, and I've said that's one of my top priorities, you need to know, what does dying with dignity mean to me? And while you're still working, I'm going to tell you a cute, well, I think it's cute, personal story. I will always be so grateful to my one sister who happened to live in Southern California, which is where my grandmother was. My grandmother was one of these very elegant women who went and had her hair done every single week, had her fingernails done every single week. I mean, she was just, whoa, very elegant. So anyway, she became very ill and was in a convalescent home and had lost consciousness. and so forth. And my sister would, and oh, I forgot to say, she had jet black hair, jet black hair. And had up until the time that she died, and part of it was because my sister would go and tint her roots for her and polish her nails.
While she was in a coma.
While she was in a coma, right? And for my grandmother, we knew that was dignity for her because that's who she was. And I always appreciated that my sister did that. And, you know, and just to tell you that, okay, if I'm dying, I don't care if my hair goes gray, and I don't care if my nails are done. So that doesn't mean anything to me, and that would be not on my list, but we know that that was my grandmother, and I just appreciated my sister did that.